today's topic is iron supplementation in dialysis patients. So we all know that how important the iron supplementation is in dialysis patients. So we'll just detailedly go through the major important parts which we all need to know regarding the iron supplementation in such a CKD patient. So starting with what is anemia in CKD. So anemia may arise as a complication of CKD. When kidney fails, less erythropoietin is produced, which results in decreased production of red blood cells. We all know that erythropoietin is produced almost 90% is produced from the kidney and around 10% from the liver. Therefore, the risk of anemia increases with the decline in kidney function and is frequently seen from CKD stage 3 onwards. So what is iron deficiency anemia? Iron deficiency anemia develops when body stores of iron drop too low to support the normal red blood cell production. Iron helps body make hemoglobin, which is found in red blood cells. When there is not enough iron, red blood cells won't have enough hemoglobin to carry oxygen, and we feel the trouble regarding secondary to the reduction of iron. So what is the role of iron in erythropoiesis? So here we can see the blood forming units and the colony forming units where the erythropoietin, which is mainly produced from the kidneys, act upon, which forms a pro-erythroblast. This is where the iron is incorporated into the pro-erythroblast, and finally the red blood cells are formed. So you can here see the pictorial depiction, like the peripheral smear picture of the normal RBCs, whereas anemic and severely anemic with iron deficiency. So there is a definite changes which you can note in the iron deficient anemic patients. So how is iron distributed in the body? Iron, we all know it's an essential body constituent. Total body iron in an adult is around 2.5 to 5 grams, averaging around 3.5. It's more in the men, around 50 milligram per kg is seen. Females, it is around 38 milligram per kg. Mainly distributed in hemoglobin around 66%, ferritin and hemosiderin around 25%, which is mainly the storage forms of iron. Myoglobin around 3%, and parenchymal iron in enzymes and all those things around 6%. Loss of 100 ml blood means around loss of 50 milligram of elemental iron, and to raise the hemoglobin level of blood by around 1 gram per deciliter, we need around 200 milligram of iron is required. So that shows how important the iron, how is the iron distributed in the body, as well as how important iron is how much amount of iron is required to rise the hemoglobin level in the human body. So in a normal condition, how much is the daily requirement of iron? So in an adult male, we need around 0.5 to 1 milligram of iron, and adult female, it's around 1 to 2 milligram, and infants, it's around 60 milligram per kg, and children, it is 25 milligram per kg, and in pregnancies, especially in the last 2 trimesters, we need excessive amount of iron intake. So it's around 3.5 milligram or 80 milligram per kg. This picture just depicts the way of how the iron is utilized in our body. So like I told, daily diet contains around 10 to 20 milligram of iron. It is absorbed throughout the intestine, mainly in the jejunum and the duodenum. Out of the 10 to 20 milligram of iron, only 1 to 2 milligram of iron is absorbed per day, which is transported via the transferrin, and around 75% of the absorbed iron is used in the production of hemoglobin, or production of RBCs by erythropoiesis. 10 to 20% is stored, and 5 to 15% for the other processes like enzymatic creation of enzymes and all those things, and loss of around 1 to 2 milligram per day from desquamation of epithelia. So there is no significant physiological excretion of iron. Actually, there is no physiological mechanism of excretion of iron. So the total amount of iron absorbed is consumed by the body in various means. So just a brief thing about the hematinics. Along with iron, other molecules are also required to for the production of red blood cells, which include erythropoietin, we all know, folic acid, vitamin B12, and cyanocobalamin. All these are equally required for the production of RBCs or hemoglobin. So are the people on dialysis at the risk of iron deficiency? Yes, very much. We all know. People on dialysis need an extra iron because of lack of iron-rich foods in the diet, blood loss during the hemodialysis, basically the dialysis loss. At the end of each hemodialysis treatment, a small amount of blood is left in the dialyzer, and this can be a source of iron loss over the time. Iron depletion due to concurrent treatment with ESA. Blood sampling, frequent blood sampling is required for the patient. So blood sampling definitely causes loss of iron. And GI related problems, which includes poor absorption of oral iron supplementations or poor absorption of iron from the dietary food products which we are consuming due to the increased production of hepcidin due to chronic inflammatory state. CKD is a chronic inflammatory state. So there will be increased amount of hepcidin, which blocks the absorption of iron from the intestine. And other uremic milieu per se will cause damage the absorption of iron from the intestine. So how much iron is lost in CKD patients? So in a healthy individual, daily blood loss is around 0.83 ml per day, and non-dialysis CKD patient, it is 3.2 ml per day, and in a hemodialysis patient, it is 5 ml per day. On an annual concern, we can see it as around annual loss in a healthy individual will be 0.1 gram per year, whereas in a patient who is undergoing dialysis, it will be 1.2 to 4.5 gram of iron is lost every year. So what is the mechanism of anemia in CKD? Like we all told, we all know, there is deficiency of erythropoietin. Erythropoietin is mainly produced in the, from 90% is produced from the kidney, and around 10% is produced from the liver. There will be reduced production of erythropoietin, which is the first mechanism. Then there will be uremic inhibitors blocking the bone marrow cells, the receptors on the bone marrow, APO receptors on the bone marrow. That will be the second cause of anemia in CKD. There will be reduced production of hemoglobin because of this. And the third one is shortened RBC survival. Shortened RBC survival per se causes anemia in CKD. And there will be reduction in iron absorption, iron utilization, which eventually leads to reduced RBC production. So that will be the fourth cause. And like I mentioned earlier, there will be increased amount of hepcidin due to increased inflammatory markers, uremic milieu, which causes reduced utilization and absorption of iron, and per se causes reduced RBC production. So this is a mechanism of anemia in CKD. There will be reduced erythropoietin formation, reduced absorption and utilization of iron. There will be a chronic inflammation which increases the hepcidin, which per se again blocks the iron utilization and absorption from the intestine. So all these things lead to anemia in CKD. Going on to the next slide. How do we diagnose and evaluate anemia in dialysis? So this is a very important slide where we just, everything is put forward in one slide. So what is the frequency of testing for anemia? These are all KDIGO guidelines. So for the CKD patient without anemia, measurement of HB concentration is required only at every 3 months in patients with CKD5 HD and CKD5 on PD also. For CKD patients with anemia not being treated with ESA, measure hemoglobin at least every 3 months in patients with CKD5 PD, at least monthly in patients with CKD5 on hemodialysis. And coming to the diagnosis of anemia, Diagnose anemia in adults and children more than 15 years of age when the hemoglobin concentration is less than 13. When there is a hemoglobin concentration is less than 13 gram per deciliter in males and less than 12 in female. And in children, the level is less than 11, between half years to 5 years, less than 11.5 in children between 5 and 12 years of age, and less than 12 like in adult females and children between 12 to 15 years of age. So that's how the diagnosis of anemia is made. And what all do we investigate? On a first line, what all do we investigate when there is a significant anemia is noted? We always get to do a complete blood count. Absolute reticulocyte count is measured. Serum ferritin level is measured. Serum transferrin saturation levels and serum vitamin B12 levels and folate levels are also measured for the investigation of anemia. So how will be after the investigation, what is the expected result for different clinical conditions? So in case of iron deficiency, so here the point of the interest for us will be in iron deficiency and chronic illness. So here iron deficiency will have the iron levels will be definitely on the lower side. Transferrin saturation will be on the higher side. The TIBC levels will be on the higher side. Transferrin saturation will be low, and the ferritin levels will also be low. And in case of chronic illness, the iron levels will be on the lower side. Transferrin saturation also will be on the TIBC and transferrin saturation both will be on the lower side, whereas the ferritin levels could be usually around normal or higher side because of the persistent inflammatory process which is going on. So these are the two conditions which is important for us right now in iron deficiency as well as the chronic illness. What is the need for anemia correction? We know what are all of the signs and symptoms of the anemia. There will be a significant pallor, chronic fatigue and muscle weakness, shortness of breath, progressive shortness of breath, decreased cognition, decreased exercise tolerance, chest pain, rapid heartbeat, and definitely the decreased quality of life, and which results in increased risk of hospitalization, progressive cardiac dysfunction, cognitive impairment, and increased risk of mortality. So correction of iron deficiency with iron supplementation causes reduced severity and complications of anemia in patients on hemodialysis. What are the treatment options we have for anemia in CKD? First one, we know iron supplementations, and earlier I mentioned the hematinics, folic acid supplementation, cyanocobalamin, and vitamin B12, along with iron, then erythropoietin supplementation, and blood transfusion if required. Iron supplementation could be oral as well as the IV supplementation. So when addressed proactively and coordinated by the interdisciplinary clinical team, there will be definite improved outcomes in cases of adequate treatment is given. So what are the rationale of using IV supplementation? IV supplementation is intended to assure adequate iron stores for RBC production, correct iron deficiency, prevent iron deficiency from developing in patients who's receiving erythropoietin. And IV iron treatment, particularly when administered, can enhance RBC production, increase hemoglobin levels in CKD patients, even when the TSAT and the ferritin levels are not indicative of absolute iron deficiency, and even when bone marrow studies reveal adequate iron stores. So we know that IV supplementation is basically intended to increase the RBC production, correct the functional iron deficiency, and prevent iron deficiency from developing in patients receiving erythropoietin supplementation. So how did the iron supplementations evolve? I'll just quickly go through it because All these are not very significantly important for for the dialysis people. So we have oral as well as IV supplementations. Oral supplementations, we have ferrous salts, iron polysaccharides, heme iron polypeptide, ferric citrates, and latest hypoxic inducible factor, proline hypoxic inducible factors molecules. So IV ions are first found in early 1950s, and that formulations are completely stopped now. And the oldest formations which is available now are iron dextran, which is found something around in early 1980s, iron dextran, and in late 90s we have found sodium ferric gluconate, later on iron sucrose, and the latest molecule ferromoxitol and ferric carboxy maltose. What are the benefits and risk of iron supplementation? Before that, we'll go to the okay. What are the benefits and risk of iron supplementation? So benefits: iron supplementation is an essential tool for the effective and efficient treatment of anemia in patients with CKD. It will rise hemoglobin concentration without any need for ESA in early stages, reduce ESA requirements in patients who do need ESA treatment. Benefits of iron treatment beyond anemia treatment objective is possible. Risk include intravenous iron supplementation is unphysiological and may acutely or chronically overwhelm biological systems in place. Infectious consequences will be there. Cardiovascular consequences can be there, and other hepatic or bone or neurological issues could be there. So comparing with the oral versus the parenteral iron supplementations. So what are the major characteristics of oral as well as versus IV iron? So oral iron, we know it is impaired by the concomitant food intake, impaired by concomitant medication intake like phosphate binders and gastric GI medications that reduce the acidity. Iron is well absorbed in an acidic medium. Iron uptake and export of iron from enterocytes via ferroporotin is inhibited by hepcidin levels, which we mentioned earlier. There will be elevated amounts of hepcidin in CKD patients, so that will inhibit the uptake of iron. And intravenous iron, it is a parenteral administration. It is readily available for usage. There is no need for the absorption of the iron. It is directly available for usage. And bioavailability, it might be inadequate in oral supplementations, and IV supplementation, it is usually high. Safety, compared with the safety profile, IV irons has got a risk of anaphylaxis, especially with the earlier molecules like dextran containing formulations, whereas the newer molecules are comparatively on the safer side. Whereas oral preparation has got severe gastrointestinal side effects like constipation, dyspepsia, bloating, nausea, diarrhea, heartburn. It's the most frequent with the ferrous sulfate molecules. So apart from hypersensitivity, the IV preparations are better tolerated by the patients, and it will reduce the pill burden also, which is a major complication for the major issue for the dialysis patient. And compared with the oxidative stress, it can saturate the iron. Oral iron supplementation, it can saturate the iron transport system if the iron level is rapidly increased, resulting in oxidative stress. Whereas in IV supplementation, stress is observed with less stable preparations, which can release some more weakly bound iron. So there is whenever the amount of freely available iron is increased, there will be increased amount of oxidative stress. And compliance, pill burden, usually 3 tablets per day is required for oral iron supplementation, and there will be significant gastrointestinal intolerance also. So there will be a significant amount of pill burden for the patient. And usually intravenous iron is in dialysis patient, it is administered during the dialysis, post dialysis, so that won't be a major issue. And convenience, definitely oral iron is administered at home, whereas in IV preparations, frequent clinic visits are required, and cost will be a definite factor where oral iron supplementations are cheap, whereas intravenous iron supplementations are more expensive. But we need to consider the efficacy as well as the few dosage required for in case of IV iron preparations. So the treatment of choice for repleting iron stores in hemodialysis patients is definitely IV therapy, IV iron therapy. So coming to the parenteral iron preparations, we have 3 generations of IV iron preparation. First generation, earlier molecules, iron dextran, which is very less used nowadays. Second generation, which is include the iron sucrose as well as the ferric gluconate. Iron sucrose is still very widely used in nowadays also. And the third generation, ferromoxitol, ferric carboxy maltose, and iron isomaltoside. Where ferric carboxy maltose, again, it is very frequently in use today. Iron isomaltoside is also increasingly being used, whereas ferromoxitol is not very much popular even now. So in case of ferric carboxy maltose, iron is in a stable ferric state, whereas a complex with a carbohydrate polymer designed to release utilizable iron to the iron transport and storage proteins in the body on a once it is administered. So coming to the advantages of IV iron, we have just briefly gone through the advantages of IV iron. It does not need long-term therapy, ensures complete bioavailability of the iron, not associated with gastrointestinal adverse events, replenishes iron stores faster and more completely than oral iron. In patients who have CKD and hemoglobin level 11 gram per deciliter without ESA, or without a significant increase in ESA dosage, IV iron raises the hemoglobin, achieves or exceeds the target hemoglobin threshold of 11 more consistently, and replenishes iron store more reliably than oral iron therapy. And data from hemodialysis patients indicate that a more intensive iron therapy with ferritin levels in the upper recommended range is associated with a lower need of erythropoietin supplementation. So coming to the choice of parenteral, when to treat anemia with IV iron in CKD. So this is the indication for treatment of anemia with IV iron in CKD. So in adult CKD patients with anemia, not on iron or ESA therapy, if an increase in HP is without starting ESA treatment is desired, and TSAT is less than 30% and ferritin is less than 500 nanogram per ml. So I repeat, in adult CKD patients with anemia, not on iron or ESA therapy, erythropoietin therapy, if an increase in hemoglobin without starting ESA treatment is desired, and TSAT should be less than 30% and ferritin is less than 500. And the second indication will be in adult CKD patients on ESA therapy who are not receiving iron supplementation, if an increase in HP or a decrease in ESA dose is desired, and again TSAT is less than 30% and ferritin is less than 500 nanogram per ml. I repeat, in second criteria will be in adult CKD patients on ESA therapy who are not receiving iron supplementation, if an increase in HP or a decrease in the amount of erythropoietin dosage is desired, and TSAT is less than 30% and ferritin is less than 500 nanogram per ml. So these are the main indications where we start IV iron supplementation. And coming to the choice of parenteral iron, like we mentioned earlier, there is definite risk of hypersensitivity or anaphylaxis with older iron preparations such as iron dextran, and it definitely require administration of test dose. Iron sucrose is a safer option, but that does not need test note, but cannot be used at higher doses. Iron sucrose administration should not exceed a value of around 200 milligram per day. Thus, correction of total iron deficit with iron sucrose require administration of multiple doses. Ferric carboxymaltose presents as a better option as it can be administered as a total dose infusion without need for any test dose, as well as higher dosages also can be administered. So coming to the chart, like ferric gluconate, the stability is low. We mentioned earlier, as the stability is low, more amount of free iron will be available, which increases the oxidative stress. So because of that, ferric gluconate is not an ideal choice for as a supplementation of parenteral iron. Iron sucrose, stability is low moderate. Maximum single dosage is 200 milligram. Total replacement, repeated doses are required, and minimum administration time 15 to 30 minutes. Ferric carboxymaltose, it's a highly stable compound. All three, the ferric carboxymaltose, ferric isomaltoside, and ferromoxidol, all are like we described earlier. It is latest generation, third generation molecules, and they are highly stable molecules. Maximum single dosage of ferric carboxymaltose is 1000 milligram. Total replacement can be done in single dose, and minimum administration time is, if it is by infusion, 15 minutes, or it can be administered as a direct injection also, which can be given over 2 to 5 minutes. Ferric isomaltoside, it's a high stable molecule, like we mentioned earlier. Again, it is also a single dose infusion can be used, and minimum administration time is around 15, almost similar values. Ferromoxidol, it's again a highly stable molecule, and similar features like ferric carboxymaltose and isomaltoside. The only thing is, isomaltoside is a molecule which contains, among the last three molecules which we mentioned, the third generation molecule, ferromoxidol and isomaltoside compared with ferric carboxymaltose has got higher amount of free iron. So there is increased chance of oxidative stress compared with FCM in the other two molecules. So just briefly going through the properties of a ideal parenteral iron. It should be stable, molecular weight more than 100 kilodalton, half-life should be long, pH should be neutral, osmolality should be isotonic, antigenicity should be low, and test dose should not be required. Time for injection should be short, and the required dose should be, the maximum dose which can be administered should be on the higher side. So which ferric carboxymaltoside adequately fits in. It's a robust iron, not associated with any much of a hypersensitivity, very low risk of hypersensitivity or anaphylactic reaction. Iron is slowly released, avoiding toxicity and oxidative stress. Rapid correction of anemia and repletion of iron stores. Test dose is not required. Short infusion time, can be administered in much higher doses than other formulation, and fewer clinical visits are required. So indication, like we mentioned earlier, who have intolerance to oral iron or have had unsatisfactory response to oral iron. So how do we determine the dosage of iron required? The cumulative dose for repletion of iron using ferric carboxymaltose is determined with body weight and hemoglobin level, and much should not be exceeded. So with a patient with a hemoglobin level less than 10, weight below 35 kg, 500 milligram is the required dose. For weight between 35 kg to 70 kg, 1500 milligram is the required dose, and 70 kg and above 2000 milligram. Hemoglobin level between 10 to 14, 500 milligram below 35 kg, 1000 milligram for people between 35 to 70 kg, and 1500 milligram for people with 70 kg and above. And hemoglobin level more than 14, below 35 kg, 500 for the iron deficiency correction. 500 milligram is required for patients who are less than 35 kg. Between 35 and 70 kg also 500, and above 70 kg also 500. So that doesn't change much in patients who is having hemoglobin level more than 14. And the maximum tolerated dose of a FCM should not exceed 1000 milligram of iron per day. Do not administer 1000 milligram of iron more than once a week. Method of administration. So the mainly used molecules right now is iron sucrose and ferric carboxymaltose. So I'll just I'll be talking only about the iron sucrose administration as well as the ferric carboxymaltose. Iron sucrose regularly used in almost all the dialysis units. Administer 200 milligram undiluted by slow IV injection over 2 to 5 minutes, or diluted in up to 100 ml of 0.9% NaCl over 15 minutes. 5 doses within 14-day period is required, and the cumulative dosage administered will be 1000 milligram, and treatment may be repeated based on the clinical response or the blood indices, iron levels, ferritin, and the TSAT levels. Method of administration: ferric carboxymaltose must only be administered by the IV route. It could be by either injection or infusion. During a hemodialysis session, it can be given undiluted directly into the venous lymph of the dialyzer. It should not be administered by the sub-Q or the IM route. And FCM may be administered by intravenous injection using undiluted solution. Like I mentioned earlier, the maximum single dose is 50 milligram iron per kg per body weight, but should not exceed 1000 milligram of iron. You can quickly go through the administration rate, which is shown in the table. So if usually it is administered within 15 minutes, and it should not be the total cumulative dose should not exceed more than 1000 milligram of iron, and the volume of iron required, FCM required 2 to 4 ml. Equivalent iron dosage will be 100 to 200 milligram. There is no significant minimal prescribed time. If the volume is more than 4 ml and less than 10 ml, it will be 100 mg iron per minute of time. And if it is more than 10 volume of 10 to 20 is required, 15 minutes is the usual administration time. So altogether, we can cut short that the minimum infusion time should be around 10 to 15 minutes for FCM administration. FCM may be administered by intravenous infusion, in which case it may be diluted single dose, but should not exceed 1000 milligram of iron. FCM must only be diluted in 0.9% NaCl, like we mentioned earlier. And dilution plan of MCM injection for infusion. For stability reason, FCM should not be diluted to concentration less than 2 milligram of iron. Inspect aisles visually for sediment and damage before use. Use only those containing sediment-free homogeneous solution. Each vial of FCM is intended for single use only. Any unused product or waste material should be disposed in accordance with the local requirements. FCM must only be mixed with sterile sodium chloride solution, 0.9% sodium chloride solution. No other solution should not be used. Parenteral administration, preparation for parenteral administration should be used immediately after dilution with sterile 0.9% sodium chloride solution. And in special situation, a single maximum daily dose of 200 milligram iron sucrose should not be exceeded in hemodialysis dependent CKD patients, which we mentioned earlier. And pediatric population, there is no much studies which has been happened in regarding for FCM molecule in pediatric patient, and therefore not recommended in children under 14 years of age. Contraindication, definitely if there is any history of a known hypersensitivity to any iron preparations or to any of its excipients, anemia not attributed to iron deficiency, evidence of iron overload or disturbances in utilization of iron in first trimester of the pregnancy. All these are contraindications for usage. Warnings and precautions. Parentally administered iron preparations can cause hypersensitivity reactions, including anaphylactoid reactions, which may be potentially fatal. Therefore, facilities for cardiopulmonary resuscitation must be available. In patients with liver dysfunction, parenteral iron should only be administered after careful assessment. Parenteral iron administration should be avoided in patients with hepatic dysfunction, where iron overload is the precipitating factor, in particularly porphyria cutanea tarda. Careful monitoring of iron status is recommended to avoid iron overload. No safety data on hemodialysis dependent CKD patients receiving single doses of more than 200 mg iron are available. Adverse effects we discussed earlier. I'll just quickly go through it. Common is like, headache, dizziness, nausea, abdominal pain, constipation, diarrhea, rash over the skin, injection site reactions, and transient blood phosphorus decreased. Alanine aminotransferase levels will be increased. Uncommon adverse effects include hypersensitivity, paresthesia, hypotension, flushing, dysgeusia, vomiting, flatulence, dyspepsia, pruritus and urticaria, myalgia, and pyrexia in some patients, fatigue, chest pain, malaise, and peripheral edema. Drug interactions. As with all parenteral iron preparations, the absorption of oral iron is reduced in when IV iron is administered concomitantly. Therefore, if required, oral iron therapy should not be started for at least 5 days after the last injection of iron preparations. And overdose administration of iron preparations in quantities exceeding the amount needed to correct iron deficit at the time of administration may lead to accumulation of iron in storage sites, eventually leading to hemosiderosis. Monitoring of iron parameters such as serum ferritin and transferrin saturation may assist in recognizing iron accumulation. So this is a gist of anemia management in dialysis, where we need to concentrate more on the iron therapy. So I know it's a bit difficult to read, but still, adults with anemia not on iron or ESA, we mentioned earlier. Indication: adults with anemia not on iron or ESA. If IV iron trial is increased to hemoglobin or decrease in ESA doses is desired, with TSAT level less than 30 and ferritin less than 500. And the second indication: adults on ESA but not on iron. If IV iron trial or 3 months oral iron trial is not functioning, if increase in hemoglobin or decrease in ESA doses desired, then iron monitoring, TSAT and ferritin every 3 months during ESA therapy, or more frequently if ESA dose changing or blood loss is present. Precautions and all we mentioned earlier, and it should be iron supplementation should be avoided in settings of infections. So summary: iron deficiency anemia is prevalent in patients with chronic kidney disease and it should be treated promptly. Anemia correction can improve quality of life and cognition in patients. Iron supplements can reduce ESA requirements. Inconsistent and inadequate absorption of oral iron frequently leads to the need for administration of IV iron supplementation. Ferric carboxymaltose combines the positive characteristics of iron dextran and iron sucrose, but is not associated with dextran-induced hypersensitivity reactions. The chemical characteristics of iron carbohydrate complex in FCM means that iron is released slowly, avoiding toxicity and oxidative stress. With ferric carboxymaltose, test dose is not required, in contrast to iron sucrose and iron dextran. Thank you.